what we're going to focus on today are BTK inhibitors that are approved for use in either CLL or other diseases. At the end of my talk, I'll talk a little bit about other BTK inhibitors that are coming for use in CLL. So this is my presentation disclosure, and I recognized this morning, but I couldn't change my slide, that I have a patent on toenail clippers that could pay out in 2018. But given that I'm in New York City, and I want to be sure I disclose absolutely everything that I'm doing. I'm sorry? That's the novelty. It gets both. And I can use it on my schnauzers too. So, how many people in the audience have heard of this drug called Ibrutinib? Anybody? All right. So, not a surprise. What an amazing class of drugs. So, Ibrutinib is a potent, irreversible BTK inhibitor, and it's a neat drug. Like most of the others that we're going to talk about in this class today, in that it binds to a target that's very, very important, in CLL, called Bruton's tyrosine kinase. It's very potent, and across the gamut of low-grade B-cell malignancies, and several other indications, including chronic graft-versus-host disease, where it's approved, and ALL, where it's being tested. And as an immune modulation agent, it has activity. It's an oral drug, which makes things much easier for our patients. They don't have to come in and out of the office. Unfortunately, as a first-in-class drug, though, it has several alternative targets that, for those of us those of you in the audience who see solid tumors and as well as hematologic cancers, as general oncologists say. It hits EGFR, so this drug can cause an EGFR rash, and in some patients, and diarrhea and other things that are associated with some of these alternative targets. The initial phase 1 study with this was performed really in a broad group of patients, and we really identified in that study, though, that about 2/3 of patients responded. And it fostered a genesis of investigation through a big phase 1b/2 study in CLL that we have the most follow-up on. And I sort of tried to focus on new things, and we have a lot of follow-up on this initial study. So in 132 patients, 101 who had prior therapy, 31 who had no therapy, we can sort of infer what's going to happen to our patients as we treat them long term. And to me, we know this drug works in most patients short term. Being able to infer what's going to happen long term as you're counseling the patients is very helpful. So when you look at the relapse patients, all of these patients received 420 or 840. The results, so there's no reason to increase the dose higher than 420 in CLL. The results were similar, and there may be a small hint that there was a little bit more side effects at the 840 milligram dose. And with this class of drugs, we know, and we'll hear about the PI3 kinase inhibitors, you see lymphocytosis early on, and this is something you ignore. And using this agent in the upfront or the relapse setting, we see approximately 90% of patients across the board respond. And as we treat patients longer, and this is from this initial study where we have almost 7 years of follow-up, we see in the untreated group, the complete response rate going up. Say the partial as the partial response goes down, and that lymphocytosis that I talked about with the class of drugs goes away with time. That's represented in a 3% at the bottom. This is response. Really what we care about is how these patients are doing long term. And this makes, a picture's worth 1,000 words in the treatment naive. And again, this was a small number of patients, but very few patients have progressed, and most of these patients, are alive. They've not died of other causes. And we still see the drop in relapse and refractory patients over time. But what's important to remember is most of these patients had a median of 4 prior therapies, some as high as 13, and most of these patients would be dead had they not gone on to this drug. So these were patients that had received a lot of therapy. What's important is that when we look at the toxicity associated with this over time, most things go down except hypertension. And we do see atrial fibrillation, the risk that continues with time. It's slow, but in most studies, I'll show it's 10 to 15%. This led to the Resonate study, which was a phase 3 study that compared ibrutinib to ofatumumab in relapsed patients. And the outcome of this is really not that important at this point. It got the drug approved. Ibrutinib beat the pants off of ofatumumab in terms of response, progression-free survival, and overall survival. But why I put this slide in today is because it's one of the few studies, even though there's short follow-up, where you can really look at the toxicity in a relapsed refractory patient. And during the time period that patients were on ofatumumab versus atrial fibrillation, versus ibrutinib, there was a higher frequency of atrial fibrillation, low-grade bleeding, rash, blurred vision. So this sort of tells us these are side effects associated with ibrutinib. And interestingly, we have our positive control that we didn't see any infusion events on ibrutinib, whereas we did see a good proportion on ofatumumab. All of these studies really led to the question: well, can we move this to the upfront setting, and is this going to have an impact? And the Resonate 2 tested this question, looking at ibrutinib versus chlorambucil, horrible comparator. Will never be a comparator again, hopefully, for as a therapy for CLL. And 17P patients were not allowed to go on this study. And again, to nobody's surprise, ibrutinib really, again, beat chlorambucil very definitively. We saw the same toxicities, in this randomized trial of atrial fibrillation and diarrhea. So cardiovascular effects we do see, not that frequently, but they do occur with ibrutinib. This looks at the long-term progression-free survival, and I want to call attention to that corner, the corner wording. Of the patients that went off ibrutinib, 12% went off due to an SAE. Only 3% went off due to progressive disease. And still, these are, true progressors, not people that where you stop the drug and their disease comes up, but progressors on this study where they progress on drug is very uncommon in the untreated setting. Again, making the point, same toxicities, but what we see over time is, again, that a fair frequency of grade 3 and 4 hypertension and atrial fibrillation. So there are a few side effects that you do see continuing with time. Interestingly, other things like infection go away with time, and this is very interesting, and probably reflects the immune protection of this class of drugs. Something I'm commonly asked is, well, what about adding rituximab to ibrutinib? And there'll be more data on this at ASH this year. But Jan Berger did a randomized trial, randomized phase 3 trial of relapsed CLL or those who are untreated with deletion 17p, where they just asked the simple question: if you add rituximab to ibrutinib, do you change outcome? And the short answer to the question is no. There's no difference between outcome. There's not a big difference between toxicity, and you might make the remission a little bit deeper, as you say, but there's no clinical benefit of that. So this is really not something I recommend doing outside of the setting of a clinical trial. Well, we talked about treatment discontinuation and why do patients discontinue therapy for CLL. And we've looked at this at Ohio State, where we've treated over 500 CLL patients, and this was our first 300 patients. And as we're managing, and I find this graph helpful, because as we're managing CLL, we sort of track out Richter's transformation, which we'll hear about later. We're all excited about the lecture, and you see that usually most patients will develop Richter's within the first 2 years, very uncommon after that. In black, we see the successive, we see that true CLL progression virtually never happens before year 1, and it continues over time. And again, this is not the y-axis is not 0% to 100%. It's tempered, and we see other events which typically early on are infections, and later on are atrial fibrillation, other side effects that make the patients have to go off and go to another therapy. The outcome of patients is very, very different based upon this. So if you get an infection early on ibrutinib, you tend to do poorly, particularly in our experience, because they didn't have other options. They had to go off the trial. If you have another event that's not an infection, you tend to do well. CLL progression is sort of in the middle, and then Richter's is horrible, and that's as depicted in brown. And so why people go off in the time frame is different. Well, what do we know about resistance to ibrutinib? And we know that about 80% of patients will, Rick and the team at Cornell and others, a lot of people work together in different papers to show that about 80 to 85% of CLL patients that become resistant to ibrutinib with CLL, the CLL outsmarts ibrutinib by mutating where the drug binds irreversibly. And in another 5 or 7%, you get mutations in an immediate downstream target called PLC gamma 2 that allows you to bypass the signaling. So it really points to this pathway as important. In other forms of resistance, probably occur, they're not that common. When we look at early progression on CLL, commonly asked, well, I get called, was somebody progressing within the first year? And my first question is, does that patient have CLL? And then the second question is, you really need to be thinking about Richter's, because that really shows up early, different pathogenesis than what's seen in CLL, that these mutations are quite rare, and we need to do a lot of work studying this. So what are some things that we do? We'll hear about, we'll hear a little bit about other strategies, but including venetoclax, which Dr. Furman's going to talk about. CAR T cells work in this setting, and using reversible BTK inhibitors not dependent upon this site. But probably the biggest thing we can do is either prevent acquired resistance by giving combinations, and an approach that we're taking, because when patients truly become resistant, they're hard to treat if they don't, because you don't know they're going to respond. You have to stop the ibrutinib. And so we monitor, since 80 to 85% of patients have a mutation that you can detect, and then we'll preemptively treat as part of clinical trials with new drugs. And we have trials going with this. Well, what about combinations with ibrutinib? The Captivate study combined ibrutinib with venetoclax, and this data was presented at ASCO, this is very, very early, but essentially you give ibrutinib for a period of time, for 3 months, and then you add venetoclax. And this was a 163 patient study. Main side effects were diarrhea, fatigue, hypertension, and cytopenias. And importantly, 80% of the patients at the extended time point where monitoring was available, where monitoring was done, were MRD negative. CR only occurred in 36% because you have small nodes, lack of count recovery, and other things. We've done a triple combination at OSU where we add obinutuzumab, and initially we give ibrutinib, and then we add venetoclax the third month. And these data were just reported in Blood, the phase 1 part, where again a 92% overall response rate, 42% seeing a CR or CRI, and these will be updated at ASH this year. Well, what about developing a second generation BTK inhibitor? Clearly, this is a good target, and ibrutinib does have several limitations. We talked, you can go, some people will have adverse events. The fact that it hits several targets, particularly with other kinase inhibitors, it's going to be difficult to challenge, to combine. And so an alternative, the question was asked, should we move forward with an alternative selective BTK inhibitor? And Acalabrutinib is one such agent, that's much more selective than Ibrutinib. It doesn't hit EGFR, it doesn't hit ITK, and as shown here, and it has very similar preclinical properties as Ibrutinib. It works in the TCL1 transgenic mouse model of CLL. It decreases B-cell receptor signaling in CLL, and that prompted a big phase 1b/2 study that in CLL, 134 patients, and the demographics are shown here. Again, most of these patients had less therapy than the initial Ibrutinib studies, but still a high-risk group. And data that were updated last year at ASH shows that this group, this was a very active agent. The progression-free survival in the untreated patients looks very similar. I'm sorry, the patients who don't have 17p or complex karyotype look very similar, with patients doing well, and even that group, the 17p and complex karyotype, are doing well. The adverse events with this, in general, most people would say that this has improved tolerance as compared to Ibrutinib, although there's a randomized study that will test that. How about in untreated patients? 74 patients went on to receive this, and again, this was a high-risk group. This trial did include 17p in contrast to the other one that we talked about, and you see the lymphocytosis. This peaks early, goes away probably a little bit earlier, although it's difficult to compare this, and it really doesn't matter when the lymphocyte count goes away. The response in untreated patients was 96%. And and the data with this, there have been very few progressions on this. The safety, has been very good. You see diarrhea, arthralgias. Say AFib is, there's been one case of AFib now on this. No cardiac deaths, and overall a very well tolerated regimen. There's a combination study of giving this with obinutuzumab was presented the first time this past year at ASH. This agent's behind in terms of doing combination studies, and obinutuzumab was given together with Acalabrutinib, again in treatment naive and relapse and refractory, small numbers of patients, and again representative of a patient group that we would treat. And we see the response is very high, and and we have a dribbling of CRs, and some of these CRs are MRD negative. Again, pointing to what we can see when we combine, particularly second generation antibodies with these therapies. This looks at the progression-free survival, and again we see both groups are doing quite well, and again, we're looking at phase 2 data. So this has also been looked at in Ibrutinib intolerance, a 33 patient cohort, and again, this was a heavily pretreated group, and all patients had come off Ibrutinib for one toxicity or another. You see the adverse events, and even in this group that were predisposed to having toxicity, nothing really stands out. This looks at the SAE that patients had, and in 52% of the patients who went on Acalabrutinib after coming off Ibrutinib for an adverse event, it did not occur. In 24% it was less, it was tolerable, and in the other 24% it didn't change. This looks at the progression-free survival of this group, and they're doing okay. And so this represents an option that one can consider if patients are intolerant to Ibrutinib. There are a variety of ongoing studies. A triple combination of Ibrutinib, venetoclax, and obinutuzumab is completed. There's a phase 2 study looking at this in Ibrutinib intolerant patients that's company sponsored, that's completed. And then the company's doing several phase 3 studies comparing it to chlorambucil and obinutuzumab, and also to bendamustine rituximab or idelalisib rituximab. And then there are multiple investigator-initiated studies with this. There are a variety of other BTK inhibitors in clinical trial that are not FDA approval. Ibrutinib is a more selective inhibitor that's being developed. There's good phase 2 data with this. It's in multiple phase 3 studies in upfront and relapse CLL. And then the Ono GS4059, again, is a irreversible inhibitor, good phase 1 data, and whether it's going to be developed. And then there are a variety of reversible BTK inhibitors that are being tested. ARQ-531 is probably the furthest along, and the Sunesis and the Loxo molecule are coming behind. So the variety of questions, we've not really talked about ibrutinib versus standard chemoimmunotherapy. Go to ASH, there'll be a lot about this, that answers this question. Does combination therapy improve outcome and allow discontinuation of ibrutinib? Cooperative group studies in the future are going to be answering this. Which BTK inhibitor do we build upon in terms of a reversible BTK inhibitor? Can we combine ibrutinib to prevent, or ibrutinib or other BTK inhibitors with other targeted agents to prevent relapse? Are we giving the antibody in the right sequence? As I say, should we give it at the beginning? Should we let the immune system recover? How do we treat BTK-resistant disease? And will the reversible BTK inhibitors work when you have the CIS41S mutation? Those are questions that we have. So I want to thank you for inviting me and apologize for going 50 seconds over.